Hi, my name is Sita Anaprampan Atmalingam and I'm doing Bachelor of Medical Laboratory Science in University Selangor. So this is my topic today, which is case study of glucose 6-phosphate dehydrogenase deficiency, which is the G6PD. So my aim of my presentation is to describe and overview the individual situation during G6PD deficiency, to determine the key issues of the case study and gain knowledge from the real situation that may give students a clear overview of the disease. To understand the nature of deficiency, risk factor and laboratory diagnostics tool and treatment for the G6PD deficiency. To learn how to manage the condition and symptom from the developing. To create awareness of G6PD deficiency and identify the clear diagnosis. For the introduction, G6PD deficiency is most common disease producing enzyme abnormalities in humans, affecting more than 200 million individuals worldwide. So the highest prevalence shows that Middle East and tropical Africa and Asia. So G6PD is caused by 400 different mutations in gene coding for G6PD. Only few of them causes of clinical symptoms of the disease. So these abnormalities shows that Kelantan, Pening and Selangor have highest frequency of G6PD deficiency. As we know that the general population on 2003 shows that 3.4% and the male have the most infected than the female. For the ethnicity, we can see that Orang Asli have 11% male have been affected than the female than other races. So what is G6PD actually? It is a metabolic enzyme is involved in pentose phosphate pathway, especially important in red blood cell metabolism. It also protected the red blood cell from effect potentially harmful the molecule called reactive oxygen species. So G6PD is located on the long arm of X chromosome band XQ28. The mutation of X-linked G6PD gene result in many variants of protein within the verifying the enzyme activity that result in different pattern of clinical manifestation. As I told you, the male cases are overrepresented compared with the female cases. Male are homozygous for G6PD gene, therefore the expression is either normal or deficient. In contrast, in female who have two copies of gene of each chromosome, the gene expression can be normal or heterozygous. The homozygous inheritance of female can occur, whereas the heterozygous female have genetic mosaicism secondary to X chromosome inactivation can have similar manifestation as male neonates. So this is G6PD gene that shows single point mutation resulting in amino acid substitution in gene encoding for G, which located the XQ28 region of the tip long arm of the X chromosome. This is a case presentation that shows Mr. Hamad, a male, 47 years old, Malaysian, a no family history, was admitted at the hospital Ampang, presented with abdominal pain, vomiting for 3 days, cough, fever and onset and having diarrhea. So this is the illness that he has been completed, which is the headache for 2 days, and it is sudden, severe and relief at rest. For abdominal pain, it is sudden and severe pain, vomiting for twice after eat. He have vomiting for 3 days. So the fever is on 39.1 degrees and diarrhea, which is loose stool for 3 days and watery stool before admission. The urine with a dark yellowish discoloration, sclera and skin for 1 day. So the family members are noticed the pale suddenly on his face and acute breathless. For the social history, we know that he is a non-smoker and drinker, no pets in house, there is no travel history. He having a balanced diet. So this is our laboratory investigation show that physical examinations, which is 39.1 degrees, which is a high, respiratory rate, which is 29, and pressure rate, which show the high plus rate. Pressure rate 128 per minute, blood pressure 131 per 71, oxygen saturation is low, and his height and waist was measured, which is 148 cm to 56 kg. A complete blood count have been done, which is WBC show 6.5, RBC and HCP is 3.8 and 9.6, which is low. Reticulocyte count is 5%, which is also low than the normal range. The bilirubin direct 3.43, bilirubin indirect 21.52, bilirubin total is 24.95, blood urea show 68.62, and the serum creatinine is 45. A peripheral blood film that have been taken from the patient shows that teardrop, Hind's bodies, and a bite cell. So these are the pictures show the teardrop. This is the Hind's body, and this is the bite cell. So what is actually the sign of symptoms of G6PD? Normally they will be having a pale skin, fainting, shortness of breath, jaundice, rapid heart rate, red or brown urine, enlarged spleen. So there will be two type of tests will be done, which is the semi-quantitative test and the quantitative test. On semi-quantitative test, there will be three tests, which is the fluorescence spot test, metahemoglobin reduction test, and cytofluometric method. For fluorescence spot test is normally a direct test that measure the generation reduced nicotinamide adenine dinucleotide phosphate NDPH from nicotinamide adenine dinucleotide phosphate NADPH plus. When it is a positive, the blood spot fail to show the fluorescence under UV light, which is the deficient. So this is the picture show that the person is normal, intermediate, and this is the deficient, which is there is no UV light fluorescence. Second is the metahemoglobin reduction test, which is a rapid indirect test that measure the reduced metahemoglobin level produced after NADPH oxidation. So first treating the red blood cell with the nitrate, converting the oxyhemoglobin rate to metahemoglobin, which is the brown color, and then examine the rate of NADPH or dependent metahemoglobin reduction in presence of appropriate redox catalyst, which is the night blue or methylene blue, and the substrate is glucose. Cytofluometric method, which is the typing assay that provides fluorometric readout of classic metahemoglobin reduction test at the level of individual red blood cell. So spectrometric assay, the rate of NADPH generation is spectrometrically measured at the wavelength of 340 nanometers. So in normal red blood cell, the G6PD activity range is 7 to 10 IUG hemoglobin when measured at 30 degrees. Testing for enzyme activity should be performed during the episode of acute hemolysis, as result may be falsely negative. A sunset red blood cells are more vulnerable to hemolysis due to the diminished G6PD level. Compensatory increase of immature young red cell with increased G6PD level usually occur in the state of acute hemolysis, and hence result could be attributed. As we can discuss that in this case study, G6PD is a genetic abnormality that results in inadequate amount of glucose 6-phosphate dehydrogenase in blood. This is very important enzyme or protein that regulate the various biochemical reactions in the body. G6PD is responsible for keeping the red blood cell healthy so they can function properly and live a normal lifespan. Without enough of it, red blood cell break down prematurely. This destruction of red blood cell is known as a hemolysis, and it can eventually to hemolytic anemia. So normally in this case, the risk factor is he is a male and his genetic profile said that as linked inherited, and he is an Asian. In this case, patient was suspected as a hemolytic jaundice G6PD deficiency in early determination. However, the treatment was not supported on the second day. The condition get worsened when the FPC and serum bilirubin decreases. Doctors suggested to repeat blood grouping, autocontrol, and indirect comb tests were negatively reported. Finally, doctors state the patient diagnosis with G6PD deficiency with the hemolysis. Managing G6PD deficiency involves avoiding the food and medication that can trigger the condition. Reducing the stress level can also help in controlling symptoms. So there is no exact treatment, however, can manage the symptom. For example, we can give oxygen inhalation, BIP, which is shown by this picture, which they using the BIP. Blood transfusion, avoid some drugs. Aspirin commonly they use for treat the pain or inflammation should be avoided. The mothball can contain of chemical of naphthalene, which is trigger hemolysis. The henna also can trigger hemolysis. And when we eating a fafa bean also can trigger severe form of G6PD deficiency. As my feedback and my advice, the detection allows the people to work their healthcare practitioner and to educate themselves about a condition that will affect them to some degree of their entire life. It does also allow people to talk to the healthcare practitioner about how this trait inherited and potential impact it may have on their children. By knowing about the deficiency and avoiding the potential triggering substances and situations, most of those who have G6PD deficiency can lead to relative normal lives. Also, patient can ask doctor to printed list of medication and food that you should avoid. So we need to have an early diagnosis, as when after we born, we can have a G6PD fluorescence test, and this will help them to recognize and manage the patient properly and give them a normal life. So this is my references, and thank you. Please like my YouTube channel and comment about my presentation. Thank you.